Good afternoon. I'd like to invite you to this month's update in pediatrics. Following the program today, you will get a CME link following the program, and you can use that or the QR code displayed in the opening slideshow to get your CME credit. Updates in Pediatrics is a monthly live stream program. It's on the third Wednesday of each month at noon. Programs will also be available online following each program at nortoncme.com. Today's topic is kids and concussions, and presenting today is Dr. Tad Seifert. Dr. Seifert is a graduate of the University of Oklahoma College of Medicine. He completed his residency in neurology at the University of Texas at Houston and a subsequent fellowship in headache and facial pain at the Houston Headache Clinic. Dr. Seifert currently serves as director of Norton Healthcare's sports neurology program and is an independent neurotrauma consultant with the NFL and serves as head of the NCAA's headache task force. He is currently the team neurologist for a number of Kentucky and Indiana-based colleges and universities and is chairman of the Kentucky Boxing and Wrestling Commission's Medical Advisory Board. So please welcome Dr. Seifert, and the floor is yours.
Thanks, Dr. McDonald. So first of all, thanks for the invitation. It's always a pleasure to be able to cover and talk about what I love to do. I'm trying to get my video going. There we go. So, the topic obviously that they asked me to talk about was concussion in the pediatric age group, and for the sake of this talk, it's going to be focused almost exclusively on sports concussion, but that's certainly translatable to other mechanisms of injury ultimately leading to concussion. But my niche in the outpatient side of things is definitely more towards a sports-based population. So that's where I'm going to be speaking from today. All right, these are my disclosures. None of these will affect the content of today's talk whatsoever. So I just wanted to start out with this.
Dr. Seifert, your slides aren't showing.
Uh-oh. Let's see.
There we go.
Okay, thank you. So I wanted to start out with this. COVID has obviously been on everybody's, the forefront of everybody's thoughts and practices for the majority of this year, and mine certainly included. The KHSAA got a late start to high school sports this year, and there are rumblings that because of the continued escalation of numbers again here in the state, that high school sports could again be in jeopardy. I looked online today to see if there was any update on that front, and I did not find anything, and I certainly don't have any information from any other source. But this was from the Courier Journal just 5 days ago. Again, just highlighting the fact that specifically with regard to high school football playoffs, the numbers are something that KHSAA is watching very closely, and hopefully they'll be able to continue to get play completed. So I like to start out with this video. This is really to start out. This is really just to highlight, despite the fact that we've made a lot of progress in the world of concussion over the last, certainly a decade, if not a little longer, there is still plenty of progress to be made. This was a mixed martial arts fight. This was in the state of Idaho, and this was only 3 years ago. So you can see what happened there. The backstory here is the fight. This is between the second and third round. This fighter had really taken a fairly significant beating, at the end of the second round, but he had not been knocked out. The fight had not been stopped whatsoever. This was just a normal, break between rounds. And you can see that he's sitting on a stool and then just acutely loses consciousness and falls to the ground. And his cornermen, at the very end of the video there, the cornermen are coming over and trying to get him aroused. And ultimately what happened, at the completion of the video that we see, is he did quickly regain consciousness. He was helped back up to a stool, and the ringside physician came in to do an evaluation, which lasted probably about all of 5 seconds. You could read lips. You could tell the physician asked him how he felt, if he felt like he could go on, and the fighter shook his head yes. He did not even verbalize an answer. He just responded with verbal cues. And I think that all of us probably would agree that this is a fighter, an athlete, regardless of age, that should not have gone back out for a third round. But despite the fact that this occurred, he did get cleared to do just that. He was allowed to fight the third and final round. Luckily there was no catastrophic conclusion to this story. He actually survived the third round and lost via decision. But I just like to include this to stress the fact that there are certainly pockets of practice with regard to concussion across our state, across the country, across the world really, where despite the fact that we've made a lot of progress and care has improved and recognition of the injury has improved and our diagnostic accuracy has improved, there are still areas where we fall short. And I think this is a good example of one of those. This is, the next couple are just football videos, just to show a distinct type of reflex that sometimes we'll see in concussion, acutely after, immediately after the head trauma. And again, this can be seen in an adolescent pediatric age group, absolutely. In fact, I have seen this in a pediatric, mid-teens aged youth male. So what you can see specifically, what we're looking at here is this receiver for, I believe this was Florida State, takes a hit, kind of gets sandwiched, helmet to helmet hit on both sides of his helmet. And then you can see even before he hits the ground, he has this kind of flexion posturing of his upper extremities. And essentially what that is, it's called the fencing response. And the pathophysiology there is, it's thought to be due to a sudden acceleration, deceleration, particularly of the brainstem region, that then immediately causes this flexion-like posturing of the upper extremities. And there's another good example of that on this play here. Again, the quarterback goes down, takes a fairly significant hit, it looks like, to his occipital, or maybe right occipital, right parietal region, and immediately has this flexion posturing of the upper extremities. This is almost always involved with alteration in level of consciousness, and this is 100% pathognomonic for concussion. If you see this, they have, in the very least, a concussion, and we need to rule out other more ominous problems also. You do not have to have this to be diagnosed with concussion. In fact, the majority of concussions do not involve the fencing response. But if you do see this, that patient has concussion until you've proven otherwise. So a few key points that I always like to highlight, when I'm talking about concussion. And again, this is concussion regardless of age group, whether it's adolescent, pediatric, late teens, or into adulthood. Not every neurologic symptom following exposure to mechanical force is due to concussion. And what do I mean by that? I always like to stress that, any sort of pre-existing issue that a student athlete has going into their contact sport participation or collision sport participation or what have you, we always have to be mindful I always have to be mindful to look at any even potential injury situation through the lens of those pre-existing comorbidities. And this is an example of that. Again, this is a case I saw in a professional athlete, but I've also seen this in a high school athlete, where in this particular case, the quarterback, this was early in fact, it was the first drive of the first quarter. So very beginning of the game. The offense was out for a series. It was a fairly brief series. I believe it was, a 3-and-out situation. So the offense came off the field and punted the ball away. But after the offense had come to the bench, the quarterback alerted medical staff that he had a headache. Okay. He had taken really no significant headshots whatsoever, and he'd fallen to the ground once after an incomplete pass. Nothing that appeared like any significant head trauma. Certainly no significant helmet-to-helmet hits. But he comes off the field and tells us that he has headache. And when you really start to dig into, what type of headache, it was certainly migrainous. It was a throbbing type sensation. He was a little nauseated, a little light sensitive. When we dug a little further into his medical history, he reported as well that this was, quote, identical to my previous migraines that I've had earlier in life. And in this athlete's case, he had a migraine migraine history documented as far back as high school, during his playing days in college. And now it certainly appeared to us at that time that he was having a migraine exacerbation. So what we did was pulled him from the game, for sake of, just being conservative until we could truly pin down what was going on. He went through a concussion evaluation on the sideline, completely negative. And he had previously treated his migraine successfully with a triptan type medication. So we had some triptan medication available. I believe in his case specifically, it was sumatriptan. Administered sumatriptan on the sideline, and then continued to just observe for the remainder of the first half. He did not go back to play. At halftime, we were able to do a more comprehensive evaluation, and at that point in time, his headache had resolved. So again, onset was early first quarter. By the time we looked at him again after medication administration, about an hour and 15 minutes later, headache had resolved. Again, physical examination, concussion evaluation, completely negative. And essentially, we decided that he could safely return to play in the second half because our suspicion for a concussion at that point was essentially nil. He played the remainder of the game, the second half, the third quarter, fourth quarter, no issues whatsoever. After the game, again, went through a physical evaluation, neurologic exam, negative. The bottom line is that in his case, with his pre-existing migraine history, he was ultimately determined to have a migraine exacerbation that just happened to be in the context of while playing a contact sport. And I think this is just another example of where, and I've certainly been guilty of this as well, where our immediate thought is collision sport, football player, headache, must be concussion. And again, that's not always the case. Often it's the case, but it's not always the case. So let me segue to what we mean specifically currently in 2020 when we're talking about concussion. Is someone recovered? What's their recovery going to look like? What are we talking about in the context of a concussion recovery? So typical recovery from a concussion, even in the adolescent, teenage age group, about 80% of athletes will have complete recovery back to baseline within about a month. But what I always like to stress, and this is where it really starts to get interesting, especially with the evolving science that we have behind this now. What we mean when we say that they have recovered and they're returned to baseline is that's essentially meaning that they're clinically recovered, i.e. symptoms have resolved. They're not having a recurrence of symptoms when we exercise or try to provoke symptoms with cardiovascular exertion. They have clinically recovered. But what do we mean specifically if we're going to dig down a little deeper and talk about neurophysiologic recovery? Does that correlate with symptoms? The short answer is it does not appear like it does. And there are numerous studies similar to this. This was a good one published in late 2017, looking essentially at fMRI data. This was in adolescent hockey players. And essentially what they did was they looked at a group of hockey players that had been concussed, studied them 24 to 72 hours post-injury, and then looked again with a repeat scan 3 months post-injury. And what they found was that in 100% of them at 3 months, even if clinical recovery had occurred, they still found abnormal radiographic findings on functional MRI. Similarly, this was a study done in college athletes at Princeton. I believe this was also published in 2017, also in fMRI. And what they did in this study was they looked at every player at Princeton, regardless of sport. It didn't necessarily have to be football. Every student athlete at Princeton during the course of a semester was, or at least they attempted to enroll them in this study, and I believe they had pretty good success in doing so. And similarly, they looked at fMRI not at 3 months, but at 2 months. And again, despite athletes, the far majority of which had returned to their clinical baseline by that 2 month mark, 100% of them still had fMRI abnormalities on the study. These were most pronounced in the dorsolateral prefrontal cortex, inferior parietal lobe. So the $1 million question with studies of this type are, what does this mean? What does this mean from a practical standpoint, from a how we manage the patient standpoint, from a long-term risk standpoint? And I think the honest answer is we don't really know. And I know that's frustrating, but I think that's the frank answer. There are a lot of potential, there are a lot of potential answers to that. Does it mean that these abnormalities are just simply a marker of previous or even subacute injury, but does not pose any sort of predictor of a patient being at higher risk in the months thereafter? Does this mean that they are still actively in a concussion recovery time period? and they are at increased risk, should they be, reintroduced to a contact sports scenario, or does it mean something else? Again, I don't think that we can honestly answer that and say that we have a way to decipher what this means thus far. There are numerous studies of this type that are ongoing. So this is just an area of concussion research where we should really continue to watch keenly. This is another study which speaks to recovery time frame. This was looking at specifically reaction time. This was from Lemke, David Howe, JT. These are all heavy hitters in the world of concussion. These are guys that provide good evidence-based publications. And this was published. This was published earlier this year in Sports Medicine. And what they found, bottom line, is the majority of studies in this meta-analysis reported a resolution of reaction time deficits in about 3 weeks to 59 days. So that's a fairly broad range, but it's not 1 week, it's not 2 weeks. The far majority of these cases seem to last at least 3 weeks before their reaction time is measured to be back to truly their normal baseline. This is another area of concussion, again, both within the pediatric age group as well as adults, that's really getting a lot of attention over the last 2 to 3 years. This was published in late 17. Concussion may increase risk of lower extremity musculoskeletal injury. And this was in collegiate athletes. And what they found is that concussed athletes were 3.39 times more likely to sustain a musculoskeletal injury in the 90 days following their return to play. So in that, fairly short-term time period after return to play, those first 3 months, they were significantly higher risk to sustain musculoskeletal extremity injury. And numerous studies have reported similar findings. And again, this is probably due to a multifactorial issue. I suspect there's some elements of reaction time deficit that is probably still present, that's portending an increased risk of musculoskeletal injury. There's also likely just some functional motor dysfunction or a fine motor dysfunction that, for whatever reason, we're not really detecting all that well clinically, that's also posing increased risk. So again, that's another interesting area of especially sport concussion research to continue to watch closely. Now, returning to play following concussion, let's get into that just a little bit. The gold standard still remains the Berlin consensus statement, the Berlin guidelines. This was from the International Consensus Conference on Concussion in Sport from Berlin back in late 2016. Yeah, regrettably, COVID has altered this somewhat as well, with the respect that the updated guidelines were supposed to come from the meeting in Paris that was actually supposed to be this month, but because of COVID, that's been bumped back a year. So there won't be any significant changes to this probably until about a year from now. The return to play guidelines, broadly state, removing an athlete from play, a brief time period of rest, and then progressive levels of increased levels of activity, initially starting with light cardiovascular activity, then more vigorous cardiovascular activity, then sport-specific activity, and then finally, if they've successfully matriculated through those stages without recurrence of symptoms, that's key, without recurrence of symptoms and not on medications that could mask that recurrence of symptom, then they're reintroduced to contact exposure, initially via practice and then ultimately finally cleared for competitive game participation. And this remains the gold standard, whether Pee Wee League football or professional level NFL football. Obviously, the time frames differ regarding, specific to age in the respect that the younger the athlete, the longer I will usually take to progress that athlete through those stages. But once you get up to a professional level aged athlete, certainly in the professional ranks or often even in the college ranks, these stages can be done one every 24 hours potentially. But again, in younger athletes, adolescent age, junior high, high school, I will often spend 2 to 3 days on each stage before progressing. So in that same vein, let's talk about timetable of return to contact. Keeping in mind that no two concussions are alike, like I'd stated earlier, whatever comorbidities or pre-existing conditions that student athlete brought into their injury, almost invariably concussion will amplify that at least for a short time period, i.e. if they have ADHD pre-concussion, there's likely going to be a time period immediately after that injury where their ADHD seems worse. If they have pre-existing anxiety or depression or even migraine, those issues are likely going to have a transient time period where they are exacerbated after the injury. Very, very common. Number one, be cautious of inflexible return to play timelines. We just talked about the Berlin, return to play guidelines and those recommendations. Those are not meant to be set in stone. For example, what we had just referenced, the younger the athlete, the longer I typically will take to progress through those timeframes. This is an interesting debate that's kind of going on in the sports neurology world with regard to limiting the number of head trauma exposures. And there's discussions of, should we limit those per practice, per game, per season, per year, per career, and a number of kind of side conversations going along all of those, different directions in the weeds. But per practice, to some respect, we're already doing that now, or at least we've started to do that by limiting the number of contact practices that can be held. We have, with the NFL in particular, there are rules now where you cannot, even an open field tackle, you cannot lead with the crown of your helmet, or you get penalized. Trying to decrease the number of head trauma exposures, even in a collision sport. There have been certain groups that have proposed, a seasonal hit count for collision sports. For example, very analogous to like a pitch count for adolescent pitchers in baseball. Where they have a set number of pitches they're allowed to throw per game, and once they reach that threshold, then they're removed and they don't pitch anymore for a period of time. Similarly, there have been proposed hit counts to where, somehow, some way, whether helmet technology or video technology, we monitor the number of hits that a young athlete takes per game, and once they reach that threshold, then they're removed. Again, there's not a lot of momentum on that right now, but these are just ideas that have been discussed, relatively recently. What about those concussions with prolonged recovery? And for the sake of conversation, by prolonged in this context, I mean 3 months or longer. And although this is the minority of patients, it is certainly not unusual. 15 to 20% of all concussions, again, regardless of age group, adolescent, teens, pediatric, young adult, middle-aged adult, this occurs in at least 15 to 20% of all concussion diagnoses. There are certainly risk factors that we've been able to identify that fairly reliably can help predict an individual that's probably going to evolve into a more refractory recovery time period. And these include the following: personal or family history of mood disorders, personal or family history of migraine, history of prior concussion, especially a history of prior concussion with a prolonged recovery. Delayed symptom onset, meaning they did not immediately declare their symptoms, the first 12 hours after injury, but it was 24 or 36 hours later. Another one, which isn't listed here, is symptom load. For example, if I see somebody in my clinic 3 or 4 days after the inciting head trauma, and on my symptom checklist, which is roughly 30 different symptoms, if they've circled all 30, that is actually reliably a predictor of somebody that's going to have a bit more of a prolonged recovery. And then lastly, post-traumatic headache phenotype, specifically someone that has post-traumatic headache that is very phenotypically similar to migraine, with the throbbing characterization of pain, the light and sound sensitivity, that nauseous quality. That particular phenotype of post-traumatic headache is also a risk factor for prolonged recovery. This was a study that I was able to be involved with J.T. Egner at Michigan year before last. And what we were looking at specifically was the fact that migraine headaches are those associated with concussion. And the short answer is yes. There did seem to be a relationship in athletes with migraine history seemingly having a increased risk of sustaining concussion. Yeah, somewhat similarly, this was another study that we published late 2017, also looking at pre-injury migraine history as a risk factor for prolonged return to school or sports. So essentially, is it a risk factor for prolonged recovery with return to sport and or return to school being the proxy for recovery? And we found that pre-injury migraine history did seem to increase both, but somewhat surprisingly, it delayed the return to school even more so to a greater factor than return to sport. If I recall correctly, I believe pre-injury migraine history delayed return to school by about 3 to 4 days relative to those athletes that did not have that. And this was in an adolescent teenage population. Staying on the topic of post-traumatic headache with those migraine characteristics, it's related to prolonged symptom recovery like we just talked about. We also know that when we do neurocognitive testing, whether it's computerized neurocognitive testing or your traditional paper pencil neurocognitive testing, that athletes that have that post-traumatic migraine phenotype, they do have greater deficits, more pronounced deficits on neurocognitive testing. So what about these prolonged symptoms? You see somebody, they've had their symptoms for 3, 4, 5 months. How do we really drill down into how we can best help that patient? And I know this is somewhat of a busy slide, but I just throw this up there to stress that, there's a lot more to concussion management than just being patient, although that's a big part of it. Time and patience is critical, but there are proactive things that we can do to try to help that individual. With regard to post-traumatic headache, your traditional pharmacological treatment regimens, procedural treatment, biofeedback. Over to the right there, I'm going to get into neck issues here in a little bit, so we'll bypass cervical. But with anxiety and mood, again, exercise, psychological therapy, talk therapy, pharmacological therapy. All of these things, essentially the rule of thumb is, how would you treat these things even if they did not have a history of concussion complicating the picture? Because it ends up being very similar, to how would you treat anxiety, or especially prolonged anxiety, or anxiety in a prolonged recovery rather. How would you treat that individual if they had presented with just anxiety with no head trauma history? You would treat it very similarly. So what about the neck? I think the neck's an important component of all of this. And this is why the upper cervical sensory nerve roots converge on the trigeminal nucleus caudalis, and they contribute to that trigeminal vascular pathway and the subsequent activation of that pathway, which is really the key nociceptive driver of headache. And when you think about certain hits that these young people can take, especially again in a contact type sport, some of these, a couple of those pictures are just examples of that, where you have, sometimes not even a direct blow to the head, but just a blow to the body, where you have that sudden whiplash like motion, that sudden acceleration, deceleration of the head and neck. Those upper cervical sensory nerve roots, when you really think about the dermatomal pattern of that, it makes sense, because C2 and C3, especially C2, goes up into the latter third portion of the head. So you can certainly have head pain despite the fact that it could have been purely just a mechanical force on the cervical region. And this is common. This was a study from about a little over a year ago, looking at cervical spine impairments in children and adolescents post-concussion. And bottom line is, they found a high prevalence, whether it be muscular tension, joint mobility issues, even decreased muscular strength. Again, super, super common. This was also published last year, looking at frequency of primary neck pain in concussion patients. And in short, it's very, very common. First 72 hours, 68% of patients report some associated neck pain. A little over a week in, you still have about half of patients with neck pain. And as far out as 45 days, 41% of patients, at least in this study, still reported some element of neck pain. So it's very common. It's something I try not to miss, because this can also certainly contribute to that refractory recovery trajectory if we're treating things relatively successfully, but ignoring the neck pain or missing that neck pain component. So let's talk just briefly about some potential exciting things coming in the world of concussion treatment. This was studied for a number of years ago, 2009, looking at gray matter changes in post-traumatic headache. Essentially stressing the fact that chronic pain alters brain plasticity, and we see that in the chronic, i.e. persistent post-traumatic headache patients. We also see it in chronic migraine patients. Persistent chronic pain changes brain morphology, and we know that now to be absolute fact. So with that in mind, there have been a number of proposals or suggestions of late here over the last 4 to 5 years that maybe there is a subset of patient that we should be treating a bit more assertively, a bit more aggressively after their diagnosed concussion. This is Sylvia Lucas's paper. Assertive early treatment of headache after mild traumatic brain injury may be warranted to avoid chronicity and disability. Again, looking at this through the lens or through the context of chronic migraine. This was from Dr. Nina Matthew, who was actually my headache mentor. This is one of his last publications back in 2011. Again, this is specifically with regard to chronic migraine, but he had suggested that timely early intervention with appropriate prophylactic treatment may succeed in reversing not only the pathophysiological changes, but perhaps even those structural changes that occur in the brains of migraine, especially chronic migraine sufferers. And subsequent studies have shown this to be true. If you can successfully treat and decrease that nociceptive drive in chronic migraine patients, over time you indeed start to see a reversal of some of those morphologic changes. It's been an exciting time over the last 18 to 24 months in the world of just headache in general because of these CGRP types of medications such as Aimovig or Emgality or Ajovy, all of which work via the CGRP complex in one way or another. And this is applicable to concussion because we know that the headache development or the initiation of that post-traumatic headache after inciting head trauma is also mediated through a CGRP dependent mechanism. And so there have been some thoughts that similarly, how we treat migraine with these CGRP compounds, that this could also potentially be helpful or efficacious in the world of acute to subacute concussion treatment, specifically with regard to treating post-traumatic headache. And indeed, there's actually a short little case series that was published late last year, treatment of post-traumatic headache with Arenumab. Arenumab is Emgality. This was an observational study. It was relatively small. I believe there were 19 to 20 patients in this report. But the initial findings were that there did seem to be some potential benefit with the CGRP, these monoclonal antibodies, and the treatment of post-traumatic headache. There's also just a side note, there's a new CGRP compound that's intravenous. I know for a fact that there are studies underway looking at treatment of acute head trauma with this intravenous CGRP compound, again, looking to see specifically if it alters the course of number one, concussion recovery in general, but certainly in decreasing the likelihood of persistent post-traumatic headache. So that's just another area, again, to watch closely with interest over the next 2 to 3 years. And I'll close with this, concussion management, just some helpful do's and don'ts that I've learned over the years. Do's, I don't need to tell you the top one there, know your patients. The better we know these young people, the better, because everybody responds differently after head trauma, but the better we can know their pre-injury personality, I've found that the more helpful that is. Education, and that's not just for the patient, but really goes without saying, goes for the parents, the administrators, the coaches, teammates. The better we can educate people on this injury, the better. And I think that that's one region one area of concussion management that we have made fairly significant progress on over the last over the last decade. Communication's key. That fourth bullet is really more so for anybody doing sideline coverage. If video is available to review, just being able to review the mechanism of injury is pretty helpful. And then knowing where and when, and having that appropriate threshold for pursuing imaging. Don't ignore serial assessments. And I meant that primarily for more of like a sideline scenario. But I think that also applies to an outpatient evaluation as well. I tend to see these young people fairly frequently after the injury, at least for the first 2 to 3 weeks. I'll often see them once a week. And I find that helpful for a number of reasons, but primarily, if I can see that certain areas of their recovery are evolving nicely, but they're still lagging in other respects, I've found it helpful to be able to provide a bit more of targeted treatment to that area that perhaps is lagging. And I just anecdotally, I think that helps with recovery trajectories as well in a positive way. And lastly, don't want to disregard input from those that know the patient well. Again, that's fairly common sense. Should go without saying. This is my contact info, and I put my cell phone on here, and I mean this sincerely. I'm always happy to communicate via text if you guys have a patient that you'd like to get in, or even if you just want to have a little curbside chat with somebody that you've got in the clinic, feel free to text me anytime. My only request is that you don't give that number to patients or parents, especially parents. But feel free to reach out. My phone is almost always on me, and I'm happy to have that dialogue with you guys whenever you have a little bump in the road or just a question. That's really all I have. I'm certainly happy to answer any questions or clarify anything. And again, thank you sincerely for letting me join you guys for lunch today. It's been fun.
Thank you, Dr. Seifert. One question for you. So if you think about NASCAR, they've really done some good work around head trauma and securing the drivers. Is there continued work with football players? We're not at they still to this day, you see them get hit in a helmet and suffer such an injury. Can they not get a more protective equipment?
Yeah, that's a good question. And especially with your point on NASCAR is a great one. And what Dr. McDonald is referring to, for those of you that might not be really dialed into NASCAR, there's a device that every driver now is required to wear. It's called the Hans device, and essentially what it does is it secures and stabilizes the head and neck region to where it moves in uniformity, or essentially it really doesn't move, so that when you have some type of impact, versus another car or the wall, you do not have that acceleration, deceleration, particularly at the cranial-cervical junction. That was the problem that led to Dale Earnhardt Sr.'s fatal crash there many years ago. And it was immediately or shortly thereafter that fatal crash that the Hans devices became mandatory. It's a little more difficult in the world of other contact risk sports like football, just because we can't really, or it's going to be tough to find any sort of device that completely immobilizes the head and neck, just because of the fact that with so much mobility that they've got to have out on the field. I will say this, though, the helmet technology continues to evolve rapidly. Where it appears things are probably headed here in the next 4 to 5 to 6 years is specifically going to be helmets that are special, that are specified to individual playing positions, i.e., receivers might have a specific type of helmet with added protection in certain areas versus a different type of helmet for linemen that are constantly taking hits on the front of the helmet, versus a punter that doesn't really get hit much at all. I think that's one area where we're really going to see a lot of, continued evolution and change and progress over the next few short years. But to answer your question, I don't know of any, specific helmet neck devices that have had really gained much headway in studies for football.
All right. And, you chair the Kentucky Boxing and Wrestling Commission. I guess amateurs wear that protective headgear in boxing, but professionals don't. Is that just for the crowds to not have that headgear? I mean, has that ever been brought up in professional boxing?
Yeah, and to clarify, by the way, I'm the former chair. I don't actively chair that any longer. The honest answer there is that the studies with regard to headgear have been somewhat conflicting. There are certainly some that suggest headgear provides a significant decreased risk for, significant catastrophic brain injury. But there are also, conversely, some studies that have suggested that headgear actually increases the risk of concussion because of the increased surface area, as well as, the slightly increased added weight to the head region, so that when they do take a hit, it just further amplifies that acceleration force. I think that's going to be, well, let me back that up a little bit. I think that's going to be an area that probably doesn't get settled anytime soon, quite honestly. I think that amateurs will always likely be wearing headgear just because it makes us feel better. And I think that likely professional boxers and mixed martial artists always will likely not. Again, just for the sake of, competing financial interest and fan interest. That doesn't make it right. That doesn't make it scientific, but I think that's likely where things will stay.
Interesting. All right. That's all the questions we have. So thank you, Dr. Seifert, for a great lecture. Remind everyone for